thank you all for joining us this evening. This is the fourth program in our Wisdom and Wellbeing series. And tonight we'll be addressing a very important topic, specifically the recognition and management of psychological distress and mental health crises in medical trainees. Our presenters will be Dr. Corey Salvett, who is a hospitalist at Memorial Sloan Kettering Cancer Center in Manhattan, and also director of the Transitional Year Residency Program. And Corey is an ACP Wellbeing Champion. And she'll be joined by Dr. Chanchal Sharma, who is a clinical psychologist at Memorial Sloan Kettering. And she is a member of the Department of Psychiatry and Behavioral Sciences. Works within the Employee Health and Wellness Department and provides institution-wide crisis intervention. And she's involved in multiple activities associated with initiatives to address the tremendous need for mental health support for employees in general and medical trainees in particular. Clearly, there's a lot of awareness and acknowledgement of issues of stress and burnout in clinicians and healthcare professionals in general. And I think it's fair to say that trainees, medical students, and residents and fellows have perhaps been an overlooked cohort among us. And since they represent the future of our profession, it's important that we turn our attention to understanding their needs. So with that, I'll turn it over to Corey and Chanchal.
Thank you, Lou, for that nice introduction. And thank you, everybody, for joining us tonight. It's great to see some familiar faces. Some of you might know me from the Small Feedings of the Soul that I helped to launch with some other members on this call tonight. And a special thanks to Chanchal. We've collaborated on this talk and have given similar talks in the regional area. And as Lou mentioned, this is something that we feel very strongly about. In general, I'd like this to be an interactive session as much as possible. So if you feel so inclined, it would be great to have your cameras on. I don't want to call on any names without any, but if you can, I think you'll get more out of it. If you put your screen on, I promise we won't pass any judgment if you need to eat your dinner, or if you're answering emails at the same time, you probably still will enjoy it a little bit more. So with that, let's get started. We're going to spend the next 45 minutes or so talking about how we can prioritize physician trainee mental health, how we recognize and navigate mental health crises and impairment. I just was curious from a show of hands, how many of you deal with residents or medical students or any kind of trainees at the current time? You can, it's okay, Mukta, don't worry. We're happy to have you. Just by a show of hands, so I see a few of you. All right. And how many of you are in any kind of, all right, more hands coming up. Excellent. So in a lot of ways, this topic, even though it's geared towards faculty and physicians who might be supervising fellows, residents, and medical students, the principles are the same. And I think as physicians, we have really a commitment to help each other and look out for each other. So yeah, so in the next 45 minutes or so, Chanchal, just if you don't mind to next slide. We're going to go over what is psychological distress in trainees. We're going to do this through case example. We're going to talk about how you manage mental health crisis of a trainee and then review some of the supports and resources. So let's start with case number one. So you just started a 2-week block as an inpatient attending. Now, for those of you who are outpatient doctors, you can imagine you might be in an outpatient setting. This might be still very applicable. It is day 1. There are 3 interns, a resident, a medical student. The team has 15 patients and 4 new admissions to see. I should know, as a hospitalist, this is very real life for me. You start inpatient rounds and notice one intern looks a bit more disheveled today. You are teaching a quick point about bacterial pneumonia, and you cannot ignore that your intern is yawning and totally disengaged. 30 minutes into rounds, you find out that the intern forgot to see a patient this morning. It's day 4 now. The inpatient service is very busy. And one afternoon, you witness that same intern having an argument with the nurse manager about the time of discharge for a patient. At Memorial Sloan Kettering, time of discharge is very important. I imagine it's very important wherever you are, but most of you know, arguing with a nurse manager is like a cardinal sin. You overhear the intern say to the resident, "All this hard work is not appreciated," walks out and leaves work early. So let's pause here. How many of you are concerned? What do we do? I mean, is this something we just say, well, let's ignore? He was tired, he was bored. Your teaching point about bacterial pneumonia really wasn't that exciting. You call your graduate medical education office, you call the intern's next of kin, you schedule a meeting. Like, what do you think, you should do at this point? I'll take some volunteers. Feel free to unmute yourself, even if you don't want to put your screen on. Otherwise, I will just call on Dan. I'm kidding.
Hi. No, if I don't know this person at all, it's probably pull them aside. Are you okay?
Okay, good.
Don't call them out in front of anybody, but give them a space, give them a couple of minutes. And I probably wouldn't take the first "no, I'm fine" at face value.
Okay, excellent. Any other thoughts about what, if you were in a similar situation, what you might do at this point? Silence. I'm trying very good not to call on anybody. Well, I think Dan, I agree with Dan that you'd want to pull the intern aside, right? Or at least there's this recognition, right, that what's going on here is certainly not normal, right? There's something that is concerning here, and you don't know that person very well, right? Maybe it's your first, or it's day 4 of your encounter with this trainee, so you really don't know their baseline, but there's enough here that makes you pause, right? That's what I'm hearing, at least from Dan. So let's move on. So should you be concerned about the intern? Dan is concerned about the intern. I'm concerned about the intern. Maybe some of you who didn't want to volunteer are also concerned, or maybe you're not sure. Are there any signs of distress in this intern, and what are you going to do about it? So you might be saying to yourself at this point, well, what is psychological distress among medical trainees? How do we distinguish what is on the spectrum of normal and unpleasant feelings, and where do we become concerned? So psychological distress is unpleasant feelings, emotions that impacts one levels of functioning. The severity can vary, right, depending upon the situation and how one perceives it, but it's really, so we think about it as sort of a continuum, right? Mental health as opposed to mental health on one end and mental illness on another. Why do we care about psychological distress? Because it impacts potentially your functioning at work, right? It affects mood. You could be, the trainee could be irritable. It might affect sleep or cause that person to not be able to sleep well. It might affect appetite. The trainee might seem distracted. There might be an increase or a spike in medical errors, disengagement from others. I mean, there's a long list, right, of how psychological distress can manifest itself. Chantal, oh, there we go. So who's at risk for distress? what are the, is it anybody who comes into signs up to residency? I mean, if you asked me that during my own residency, I might have said yes, this feels like a torture for 3 years. But the reality is that increased clinical demands, this chaotic work environment where you don't have a lot of control over your time, your schedule, the electronic medical record definitely contributes to this feeling of distress amongst trainees. You don't have as much time as we used to with patients. There's a feeling of isolation or disengagement, right? You might have to miss family get-togethers because you're on call. And there's this struggle that trainees feel where they're really don't always know how to balance personal and professional responsibilities. Next slide, please. Along with that is depression and medical training, which there's the sobering facts is that quite a large number have depression or depressive symptoms in residency. 29% based on a meta-analysis of 54 studies show this, where there's 15.8 increase in depressive symptoms during the first year of residency, and it continues over time. So a lot of studies have shown that actually depression can start as early as in medical school and then just continue to get worse. So I mentioned already some of the signs of depression in medical training. Some of the other things to look out for: not returning pages on time, sudden changes in punctuality, disengagement, medical errors, and so forth. So the most severe, I think, or the worry that as a program director, somebody who oversees trainees at their PGY1 level, is suicide. When I became program director in 2014, it was soon after two different institutions had suicides in their PGY1 year. And it was 4 days, it was literally 4 days later. And I thought to myself, like, oh my God, like this is so intense and my worst nightmare. And I think it's every doctor's nightmare that they should lose a trainee to suicide. And not even trainee, a colleague, a physician. I think we all have known somebody. There's 6 degrees of separation. So this is a serious and real threat to the members of our community. And it's estimated that 300 physicians die by suicide every single year. Females have a 2.27 times higher than the general female population. Males 1.41 times higher than the general male population. You're at risk for suicide if you have a history of mental illness, substance use, hopelessness, access to lethal means, inadequate support system. So what are some of the signs that you need to think about suicide, or that a colleague or a trainee might be thinking about engaging in self-harm? So I mentioned already that this withdrawal, right, or disengagement, but withdrawal from friends and family and normal activities is one of those signs. Giving away personal possessions, saying goodbye like they're going away forever. A preoccupation with death is another one. Stockpiling pills or obtaining a weapon, though I think in a supervisor role, right, where you're on the wards or in the clinic, that might be hard to see. But you might, if you pay attention, you might notice that that person is taking steps to tie up loose ends or organize personal papers, paying off debts. Sudden mood changes after a period of despondency. So these are just some warning signs, right? It's not a definite, right? If you see this, that they must be, that they must be planning a suicide, but I definitely think that these are signs that should make you pause and, again, pull that person aside and be like, are you okay? What's going on? So there's a nice framework similar to what we think of in pediatrics, so the APGAR model for recognizing signs of mental health distress, where A stands for appearance, right? Decline in self-care, fatigue, weight changes. P for performance, where you have increased medical errors or other performance issues. Growth tension, apathy, irritability, feeling overwhelmed, affect control, moodiness, difficulty managing emotions, and relationships, struggles with existing relationships, social isolation. So this is a useful tool, right? If there's something I want you to remember, maybe take a screenshot, of this slide, so that you can, this is sort of a nice, easy tool to remember. So let's go back to our case, right? So we talked a little bit initially about what are some of the things that we were concerned about, but we didn't really tease into it too much. So if you use the APGAR model, we'll use it now. We decide that this trainee actually has several signs to suggest a mental health issue. The trainee is disheveled in appearance, seems irritable, which is not the norm for this person, some psychomotor agitation on rounds, and performance and professionalism issues, right? So they've left early, they're fighting with the nursing staff, making medical errors, right? So there are a lot of flags here, red flags that tell you, something's cooking. So you decide that you're going to meet with this trainee and you find this. You listen compassionately, and the intern shares pretty soon into the start of the meeting that he has not been sleeping or eating well. He's troubled by the many sick patients on his service, and he has ruminating thoughts about one young patient who died recently. A few minutes later, the intern admits he's feeling blah, he has thoughts of not wanting to be alive. You ask the trainee to elaborate. He shares he is having thoughts of self-harm with a plan and intent. You try not to freak out, but you sort of are, right? And it's 6 p.m. and you're like, what did Corey and Chantal teach me how to do, right? If I was in the situation, right? So you decide it's probably best to walk the trainee over to the psych emergency room at New York Hospital. It's across the street. But if you were working somewhere else, you might identify that local ER. The trainee resists at first, but then at least agrees to be evaluated. So I'm going to hand it over to Chantal, who's going to walk us through the steps here, right? So this is the way we presented this case. It's a very, very nice, right? The trainee agrees to go. He admits so nicely that he's having feelings of suicidality, right? But it's not, trainees, just like patients, they don't read a textbook, right? They don't say, well, I'm going to have this problem today and I'm going to follow all these steps. So Chantal, why don't you walk us through when things get a little bit more complicated or not so clear cut?
Sure. I think though, I'd like to sort of, go through this algorithm and just highlight sort of the steps needed for these three various situations, one being life-threatening, so that's a danger to self and others. The second is it's urgent, right? So this is someone who you're really worried about, but not quite sure whether or not there's suicidality. It's just very unclear. And then the third being non-urgent. This is when there's no immediate concern or safety, but that it would be really beneficial to direct this trainee to the available resources within the institution or even externally. So it's important for us to know what to do, not only in emergent situations like as Corey mentioned, sort of an easier one that we just presented, but especially during those incidences of ambiguity of the trainee's disposition. So the first step is for us to determine how distressed the trainee really is in order for us to ensure his or her safety, or is it just to sort of, again, direct them to the resources? And now bringing it back to the case, right? So it's clear that the trainee is in distress. So what else do we know? We know that he has admitted to thoughts of hurting himself. Right? He's got a very specific plan. So if someone comes to you and says, I'm going to overdose on pills, or I'm not quite sure why. I mean, we live in New York City. The 6 train seems to be a method. I've had multiple people come up and say that they would jump in front of the 6 train. And I think, so more importantly, though, he intends to sort of carry this out. When Corey's speaking with this with this trainee in the office, she gets the sense that he's gonna carry this plan out. And then he doesn't have the ability to really identify deterrence. So lots of people will say, my children, that I would never do this because of my children or parents or, even religious beliefs. This is a sort of, as Corey mentioned, clear case of like an urgent life-threatening situation, right? So here he agrees to be escorted to the ED, but if he hadn't, calling 911 or requesting an ambulance to come in to take him to the ED would definitely need to be initiated. And also, calling security on premise to ensure that he doesn't flee. That's a bit, I mean, that's happened. So, having security knowing their information, their number when needed is really important. So what if this wasn't so clear cut? What if he had been, what if he shares he's having thoughts of self-harm, but there's no specific plan? It's just sort of fleeting thoughts. And he tells you that, in the past, he's seen a therapist in college, and it's because of a long history of depression and suicidal ideations that he was having, and that he saw a therapist for that. And then he doesn't have, also the other really important thing is, asking about support systems, and if he shares that he doesn't have any family or support in New York, or he's kind of on his own. So while this may not be life-threatening, it is very concerning due to the history of the depression, right? So this was one of the risk factors that, the risk factors for suicide that Corey had just mentioned, right? So in this case, right, you can sort of partner up with someone in your institution that could really guide you about next steps to further support this trainee, right? So this could be someone in the department. It could be a mental health clinician, or like if you have a mental health program on site, they would be, ones to reach out to. Oftentimes employee health, occupational health, is definitely, I'm part of employee health and wellness. We sort of have this relationship with HR about these kinds of workplace concerns, and we really go in as a team, and definitely not in any sort of punitive way. But it's good for everyone to sort of know the processes and go with this. So what if the trainee mentions, let's say, that the third situations, right, sort of that he mentions that due to the recent death of that child that he was sort of caring for, he's got thoughts of death and dying, but has no plan, has no intent, and he identifies that his parents are his deterrents, and that he feels that he can actually reach out to his good friends, and he has good colleagues that he can sort of speak to. So in this case, you would sort of encourage the trainee to seek professional help, and direct them to mental health resources for support. And again, this is a big one because, especially if it's someone you have a good relationship with, you feel connected with, if you encourage them to see a professional, I think it goes a really long way. They actually do so. Okay, so here is a tool to sort of assist you in sort of determining what action you'd like to take when supporting a trainee who may be experiencing a mental health crisis. So the slide prior, where we were sort of going through these scenarios, you can actually use this triage tool to determine what step to take in that algorithm. So I admit that there is a lot going on in this slide, and I won't go into too much detail, as this is sort of meant to be used as a reference and a guidance for the possible scenarios of a trainee in distress. It is important to note that this slide sort of describes the critical factors, right? Such as the observed behaviors of the trainee's report of his or her experience, and what actions they're sort of displaying, and encountering in various situations involving a trainee. So this triage tool is what we encourage folks at MSK to utilize in guiding them through these often very stressful and difficult situations. And you can sort of adapt something like this similar within your own institutions. As you can see, the action, the bottom portion of this is very MSK specific. This is kind of how we manage a crisis here.
But I just wanted to interrupt for 1 second. if you just go back. So EAP, for those of you who may not know, is Employee Assistance Program. Many institutions, not just Sloan Kettering, have something like this in place, and it's an anonymous phone number that you can use that can help a trainee or just actually any employee with a mental health issue. And many hospitals now have realized that employee health is important and have their own departments or, resources. So just make sure you identify what resources are available to you in your home institutions, because you'll be surprised if you haven't looked into this yet, that there are quite a robust resources, even when you weren't expecting it. Sorry for the interruption.
No, thank you, Corey. And I'm actually gonna, this is great because I'm actually gonna talk about EAP programs. So it's you've done a nice introduction, so it's perfect. All right, so back to our case, right? So I imagine every institution has some process like the ones that Corey and I are sort of presenting. MSK's main campus, like she mentioned, is a block away from Cornell Hospital, and on multiple occasions, we've walked distressed trainees and other employees who are sort of cooperative, who agree to do this, to the ED instead of calling 911. So that's the last option. And many times in my office, I think in my 14, 15 years of career, I've only had to call 911 once on an emergency case that wasn't willing to go. I've even pulled in like training directors or, their supervisors or managers to help. And that's actually gone a really long way. They've come with us to the ED. So if the trainee is reluctant though, again, call 911, the ambulance. When you arrive at the ED, now this is all sort of recommended suggestions. This is kind of what we do here, and it's been very helpful. So we wanted to share this, with you. But giving a sort of a brief synopsis of the trainee's presentation to the psych attending at the ED is very, very important, because oftentimes when people go in, it can be a scary thing and a crazy and a scary sort of place, right? And so they're afraid of being sort of locked up or being put away are the terms that are used. So I think it's important for the attending to have our account of what has been presented. And I think that most people in these situations are appreciative and actually have said to us later on that they felt supported. Also, I think I usually will ask a trainee whether it would be all right to reach out to their family member or emergency contact to inform them of their whereabouts without going into so much detail, right? So this is especially important when the trainee happens to have children at home, or they're picking up children, or they have pets, or they have an older parent that they're caring for. There needs to be someone else who can make those arrangements in those kinds of events if they're hospitalized and admitted. So I think it's important to notify leadership as needed, going to within the institution, going to the department, finding out what the protocol should be in terms of informing them of these kinds of situations as confidentially as possible. And so here at MSK, right, when the trainee is sort of ready to return, he or she may reach out to employee health for further instruction and clearance to return to work. So this is really important. And we ask for documentation for their return to work. So this is mainly to ensure that the trainee is in care with a treating clinician. So if this is someone who we're so worried about, even walked someone to the ER, and where, we want to ensure that they are in care, right? So we ask for, documentation from their therapist or psychiatrist who can attest sort of to the reduction of their symptoms and an increase in an overall functioning, and can attest that they're sort of ready to return to work. And we can make those kinds of accommodations, and we have done so through employee health. So, here are some of the highlights, right? So the key elements that helped assess and triage here in this distress trainee. So it was observed, right? The distress was noticed, it was recognized, it was observed on several occasions, and indicating that the trainee was experiencing possible mental health distress, right? So such as disheveled appearance, being unprofessional, poor interpersonal interactions with others. The approach utilized with the trainee was compassionate. I know we keep saying that, but it's super important, and addressed as quickly as possible. And another very important thing, to just keep everyone safe. Using face-to-face meetings for such things goes a really long way. I usually have people come in person for these kinds of things where I can actually get my eyes on them and get a real sense. It's hard to do through Zoom sometimes. And so that's something that we ask trainees and other employees to do. And then, of course, the triage tool was utilized to guide. Okay, so I'm going to pass it back to Corey to introduce our second case that's related specifically to impairment.
Thank you, Chantal. So I hope by now, in this last 30 minutes, you realize that you don't have to be a trained psychiatrist or psychologist, right? We're really focusing on observations of behavior, appearances that are going to get you to pause, and then we want to give you the tools to address them, because we have a responsibility as physicians, supervisors, to act and not to be, not to just explain away. All right, so let's start with case number 2. I think this is something that maybe doesn't happen as frequently as the first case, but in some ways can be a little bit more intimidating. So you are excited to be working with ML, second year HEMONC fellow in clinic this month. You first met her when she was a PGY2 during her general medicine rotation. You worked with her for 2 weeks on the inpatient service and you thought she was a star. As the clinic block starts, you cannot help but notice that ML seems different. She's lost significant weight since you supervised her several years ago. You discover that the fellow has arrived 15 to 20 minutes late each morning and seems tired, irritable, and anxious. The clinical staff mentions to you they are concerned about ML. She's been abrasive with staff and has made a few basic medication errors. You are now seeing a new patient in clinic who is very ill with hypotension, fever, and tachycardia. You activate the system to send the patient to the ER and notice the fellow seems totally uninterested, withdrawn, and in a bad mood. Surprisingly, the fellow disappears, and 10 minutes later, she returns and seems upbeat and happy. Her eyes look a bit watery and red. So let's pause. How many of you, by a show of hands, would be at all concerned at this point? All right, Nanzini, you've got your hands up. Lynn, I see a few others. Okay. Nanzini, would you mind sharing, since I know you so well, what is it that you're concerned about?
She's showing many signs of depression, but also substance use, which is really significant because it can impair an ability to take care of patients.
Okay. Any other thoughts from the group? Because quite a few of you raised your hand. I think Stephanie maybe raised her hand also. Yeah, you did. Do you want to share what you were concerned about?
Hi. I just want to introduce myself. My name is Stephanie Brannigan. I also am in New York City. I work at Mount Sinai Beth Israel. And I am a new attending. I'm a PGY5, but I've been doing, since I got to where I am, I do a lot of wellness work with the residents. So this is right up my alley, and I'm happy to be here. Nice to meet everybody.
Thank you so much for joining.
Yeah, I agree. I think the resident is using some sort of substance, and I think that it should be addressed.
Okay. All right, excellent. So I'm glad to hear nobody would say ignore, right? She's just under stress, she's sleep deprived, and I'm glad you're not all running to call human resources or scheduling a meeting at the end of the rotation, right? So this is clear that something's cooking, something's concerning, and we probably need to address it pretty quickly. So before we get into the nuts and bolts of how we're going to address it, let's take a few minutes to review impairment in the workplace. So as you recall, in the beginning of the talk, we talked about psychological distress in larger terms, right? And so by definition, impairment in the workplace is the inability to focus on tasks and carry out the usual job responsibilities. And it can be driven by substance use. It can also be driven by mental health difficulties such as depression and anxiety, psychosis, like we discussed in case number 1, medications with certain side effects like brain fog and sedation, extreme disruption and sleep, or some acute life event like the death of a family member or death of, or severe change in financial status, living situation, maybe a divorce, right? So the cause of the impairment, is really multifactorial at times, and a lot of that differential diagnosis. So what are the signs and symptoms of impairment? So similar to what we discussed earlier is that, that APGAR, right, that we use for mental health issues, right, is that physical appearance, right, deterioration in appearance. They look disheveled, maybe bloodshot or droopy eyes. There may be a smell of alcohol. Pupils might be changed, whether they're dilated or constricted. A person might be flushed or incoherent in speech. There may be changes in their coordination or an unsteady gait. They might be drowsy, falling asleep during your rounds or clinical encounter. You might have mood disturbances, irritability, inability to verbalize thoughts, being paranoid, interpersonal conflicts, being late to appointments, unknown whereabouts, right? So similar to what we discussed in case number 1, again, kind of reminding you what those signs and symptoms of impairment are. And definitely sounds like in this case, we're getting some of that here as well. So based on the trainees' behaviors, you're definitely concerned, right? And there's evidence for reasonable suspicion of impairment. And we phrase it this way because you don't know for sure what's going on here, right? I heard quite a few say, well, I'm concerned about substance use, right? But we don't know. But there's definitely some observations here. We've got red eyes. The fellow is jittery. There's obvious weight loss and mood changes. And sudden mood changes, right, in a brief clinical encounter. And there's some atypical behaviors, right? This fellow is irritable, frustrated, distracted, consistently late to clinic, unknown whereabouts, right? The fellow disappears while you're supposed to be sending off this critically ill patient to the ER. So you definitely are concerned. So what are the important next steps? Again, we're not trying to turn you into a psychologist, but the key here is that you're recognizing that this is concerning behavior. You want to make sure you gather any other supporting facts and observations, not assumptions, right? We don't want to jump to conclusions, and you want to set up a meeting with this fellow as soon as possible. So if this was me, I would probably arrange for that day, even if it meant staying an extra half an hour later or delaying a patient. You have to address this on the spot, right? The longer you wait, you can run into more trouble, and we put the fellow might be really at serious risk. The other thing is that you want to identify your HR employee relations advisor. That's who we have at Sloan Kettering, but I imagine, and we know that in your institution, there is something similar to that. Different, they may have a different name, but if you're not sure, you can call your human resources department and find out, who that point person is. And the key here is that you're not doing this in isolation, right? You're partnering up with somebody else in the institution to come up with an action plan, okay? And that's one of the real take-home points here, right? Is that you're recognizing, you're concerned about the trainee, you're having a meeting, and you're getting your backup support, right? And if you're unclear, you're going to call maybe you'd call your graduate medical education advisor, or maybe the DIO, but you are going to make sure you have some support as part of your action plan. So when you actually meet the trainee, ideally, it should be in person and as soon as possible. And again, we've said this 3 times now, but you're going to listen compassionately, right? It's very hard for a trainee to open up if you've already got a lot of judgment, right? So you want to be careful about your nonverbal cues, right? You don't want to have that grumpy face on, it's harder to open up to somebody like that. And you want to make sure that you're always using discrete, it's very specific, observable, problematic behaviors of concern. You don't want to ever engage in arguing or bargaining with the trainee. And that you want to be sure that you're going to be prepared to present a specific plan of action and obviously indicate clearly what the consequences are of not following through with that plan. So for example, the assessment and treatment are a condition of their employment and so forth. So we go back to the case. You decide that you're going to meet with this fellow later that day, and she agrees to meet with you, which is good. You tell the fellow you are concerned by some of your observations in clinic, such as showing up late to clinic every day, irritability, and mood changes. And so you'll see here, I'm using some regular, very common feedback techniques. I'm telling her, right, exactly what I'm seeing and what they are, right? So there's no guessing, right? It's not vague, it's very specific. The fellow acknowledges that she has been late a few times, and she reports not sleeping well. She's been up nights in a row working on research. You listen compassionately. She shares she's also been feeling anxious and pressured that she is not as productive as her co-fellows. You tell the fellow you are concerned and want to help her. You explain that you plan to contact the HR employee relations advisor to determine next steps. You explain that based on the HR's recommendation, you will contact employee health, who will decide if she needs a formal clinical assessment. So what do you notice before we talk about next steps? Anything you notice about this meeting? If I'm the one leading the meeting, I didn't say, hey, I'm worried about drug use. Right? Or I'm not, accusing her of doing that, right? And what you'll also notice is that the fellow is not coming out admitting to any use here. Caroline says you are being concrete and discreet, and that is correct, right? So the goal here, right, is to come up with, get the not to alienate the trainee, right? Because I think if you start pointing fingers without the evidence, without this trainee admitting to certain things, you run the risk of her not cooperating, right? And the key is that we need to get her help, and you alone are not going to be the only one to help her. So it is very important. So now that you continue to get buy-in. And so now what are the next steps? Again, you try not to freak out, and you contact the HR employee relations advisor, who says that, yes, this person, based on the observations and the behaviors you're reporting, a formal clinical assessment with employee health is needed. You contact employee health and make arrangements for this clinical assessment, and you escort the trainee, walk her over to employee health. So again, here, similar to our first case, we are not sending the trainee off and saying, okay, the emergency room or employee health is located on 70th Street, walk on over, send me a text message when you arrive, right? You have to make sure that there is handoff here and that you're escorting for the safety of the trainee more than anything else. So I'm going to hand it over back to Chantal to go over our process for reasonable suspicion of impairment in medical trainees. And you'll see that there are definitely some similarities to our first case.
Okay, so before I even dive into this algorithm, there are a few critical points that are related to reasonable suspicion of impairment. As you may have noticed in this case, and in most cases, the trainee is unlikely to admit to using substances, right? So, which is why it's so important that we know the signs, we recognize them, and we know the atypical behaviors. This is out of the character for them. And as Corey mentioned, it's crucial to address the issue with the trainee in the moment or as soon as possible. So specifically, I think if the observed atypical behaviors do point to an impairment that is due to a substance, right, it would be reasonable to sort of include within that employee health assessment drug and alcohol testing as part of the evaluation. So, and this would be most representative, if conducted on the day when the trainee is exhibiting these behaviors. So now we can take a look at the algorithm for the sequence of events, right? So if you and or the program director observe concerning behavior, right? You observe the behavior, you meet with the trainee as soon as possible to discuss these behaviors, and you inform him or her that you've sort of partnered up with HR to ensure their safety and others' safety around them. So again, HR involvement is not punitive. It's to sort of provide advisory services and to address any workplace concerns and even accommodations later on when they need it. And then the training director and HR determine if an evaluation is warranted, at which point the trainee will be informed that he or she will be escorted to employee health for the evaluation, and it includes medical, mental health, and possibly toxicology testing. And this is a standard process for all employees for what we call an administrative or a mandatory referral such as this. So what happens if the trainee refuses to cooperate? So the training director should inform the trainee, again, the evaluation is mandatory, a condition of their employment. And if the trainee continues to refuse, then you can sort of contact HR to discuss the next steps. So if testing is required due to suspicion, trainee will return to work until the results, they will not return to work until the results are available. And finally, ensure that you facilitate their like safe transportation to their home or the ED, especially if there is substance at play here. And we have sort of I'm not going to get into it, but we do have a similar process in place for after hours, weekends, and holidays. It's pretty much similar. The folks like at HR and employee health, sort of change roles in some way. But
Chantal, Mukta has her hand up.
oh, okay.
Yeah, no, thank you. First, thank you for this very informative talk. I had a question. We are basing this particular algorithm on suspicion. Do we need to get approval from legal counsel or something before we walk a person over, a resident over, or can we do it just on suspicion?
So this is called reasonable suspicion, right? So it means you suspect there's some substances, but you don't know. And until that clinical evaluation is completed, I think we'd hold off on that. But Corey, I'd be interested to hear what you
I think
as well.
I think that we wouldn't get legal involved just yet. I think the key here is, as a supervisor, program director, you want to be very clear that your intention is that you're concerned, right? And that these are the reasons in that very concrete way, right? The same way we give feedback, like in this very concrete way. And it's okay, right? To get evaluated, we really want to focus on the trainee's safety. And again, I think you have to go step by step. If the trainee does not comply, I imagine at that point, HR, when you're contacting HR, they will probably involve legal. But my guess is that, and this is, speaking from personal experience with trainees who have been struggling, and not necessarily in the case that I had, it was somebody who was visibly anxious, depressed, not, psychomotor agitation on rounds. And I basically pulled him aside and I mandated that he had a day off, right? Because, this was after, a meeting and so forth. I'm kind of fast forwarding, but he was relieved, he was actually so appreciative that I noticed, right, that something was off, and thanked me for caring. And so I think certainly in the trainee population, when there is that sort of somebody's noticing, not everybody is going to be, resistant. But I do think that when there is, I imagine that we would have to get legal involved when there's resistance to getting help, resistance to an evaluation. But yes, it's definitely tricky, and you have to use your supports in your specific institution and know sort of the ins and outs, right? So here we're sharing with you the guidelines that we use at Memorial, and it's similar to what's used at Cornell Medical School. But Chantal used to work in Montefiore in the Einstein system, so it's I would say this is a general sort of outline. Obviously, I would check in with your home institution for like some of the specifics, but I hope that helps answer.
No,
your
no,
question, Mukta.
absolutely. And like you said, most of the times it's the trainees who you've developed a relationship with, or you can get their mentor or somebody involved. We just had one issue in the past 5 or 6 years where it got really a little confrontational, and we are trying to work around that. And most of what you said is exactly what our legal counsel said also, that the program director has to do it in the safety of the person they are caring for and for their patients. So I just wanted to sort of see other people's opinion. We had a lot of controversy in our own institution, but thank you for sharing.
I think the flip side is, if you had this reasonable suspicion of impairment and you didn't do anything, and then something terrible happens to the trainee, I think legal would have to get involved there as well, right?
Absolutely.
So I think this is very much an art, as well as it is a science in terms, right? So just like the way patients don't read textbooks and we have to pull together our clinical reasoning, I think you do have to use your judgment, when you're supervising trainees and when there is suspicion of impairment or any kind of psychological distress. So in the interest of time, I think we're going to move on. We want to just share, the take-home points, which is mental health issues, including anxiety, depression, suicidality, as well as impairment, are prevalent in physicians. We are very much humans like everybody else. And for many on the call in our other programs, we talk about the human experience. And mental health issues and crises can present in a wide variety of forms in the work setting, specifically lack of professionalism, coming late, behavioral changes. And so early recognition is key. You want to make sure you're always on the lookout for mental health issues or crisis. I think we've come a long way in terms of reducing stigma on the whole, but there are still institutions that, there's still a lot of stigma associated with mental health issues, and it's hard sometimes for an individual to get help. So we want to make sure we're always working towards creating that culture to promote utilization of both internal and external mental health resources, that we're reminding our trainees, we're reminding our physician leaders and supervisors, what's at your fingertips. And very often we're surprised, right, at how much is really there for us. So in the last few minutes, I think Chantal, Dan, you have your hand up. So before we had share some resources, just wanted to, Dan, you're muted.
Yes. Okay. Sorry. In some ways, all of this stuff represents the culmination of a process, right, of trauma and maladaptive coping. What we haven't talked about here, and I'm just putting a marker down for things we need to talk about in other sessions, the preventive stuff, setting up programs of opt-out counseling so that people are already in the habit of getting help long before we have to walk them to get help. And, really thinking about how we organize our training programs so that this becomes something that is not, so much more frequent among our trainees than it is among the rest of the population.
I completely agree. I think that really starting from the beginning on day one, creating that culture of psychological safety, creating the culture of wellness, being able to be open and share, something that we developed here at Sloan Kettering a few years ago with Chantal is psychosocial debriefing sessions where we reflect, we get in the habit of talking about our feelings. It's a very different experience than when I was in training where, even as a junior attending, I went to the bathroom and cried, I wasn't allowed to show any emotion or, so I completely agree. I think that as, physicians on the front lines in all different clinical settings of many of you on the call today, it's still something we need to be on the lookout for. And hopefully with time, we will be able to reduce the prevalence. We've got 3 minutes left, Chantal. Do you want to just open it up for questions and thoughts?
Let's just do that. And I'm happy, we're happy to pass along, these resources.